That is my son Elias making noises in the background. Hey, bonjour.
She's asleep in the car.
All right, it is 5:31, so I'm gonna go ahead and get started. Welcome to this edition of the Trauma-Informed Care Task Force. It is great to be with you all. It feels like it's been a really long time, even though it's only been 3 weeks, but 3 weeks too many. So it's good to be with y'all. My name is Zeke. I am the City Council person for District 1 and chair of the Trauma-Informed Care Task Force. Today is Thursday, July 7th, 2022. As a reminder, this meeting is being recorded and is being played on YouTube. So we are live. I am really excited for both our work session today and also our DEI, where we are going to hear directly from Nika Namdi, who is going to share some of her work with us. And I also want to get folks ready. I know that a number of people participated in the letter to Mayor Scott around Baltimore City crisis response. We have some really good news on that. It's not the full amount, but it is a really meaningful amount. I can't quite disclose how much yet, but soon to come. But really, really excited to partner with the mayor and BCRI on that, and just want to publicly thank this task force, and particularly the leadership of Fariha and Nika, for advocating. We know that mobile crisis response is critically important as we think about rebuilding our systems and not just relying on law enforcement to do everything, especially things that they really are not well equipped to do, including mental and behavioral health crises. And so, again, I want to just thank folks for the advocacy because it really, really, really made a difference. Okay, so with that, I am going to turn it over to Anne for our question of the day and our rounds question.
All right, thanks, Zeke. It's so good to see so many people on. Our rounds question for today is we're going to share a high and a low. And I've made the groups a little bit larger today. For most groups, there's 3 or 4 people in a group. So we're going to stay in groups for a little bit longer tonight. So give me 2 minutes. People have joined. I'm going to get them assigned, and I will go ahead and open all rooms. So high and a low. For folks that have just joined, we are in breakout rooms right now, and we're going to be coming back in a minute. So I'm not going to send you to a breakout room. So feel free to just hang tight, and folks will come back together. Hey, Adrian.
I was just saying sorry to be late. I was getting the babysitter set up. So
You're totally fine. Thanks for joining us tonight.
yeah.
Being recorded.
All right, welcome back. Outstanding. So I do want to just welcome, I see Krista Taylor is with us from Behavioral Health Systems Baltimore. Thanks a lot, Krista, for being here. Excited to hear from you all. And I see Adrian as well. Looking forward to hearing from you all as BHSB, and definitely appreciate you joining the Trauma Informed Care Task Force. With that, I am going to hand it off to our friend Nika Namdi to do, actually, no, I'm sorry. I'm going to hand it off to Fariha to introduce Nika Namdi to do our DEI presentation for today.
Thank you, Zeke. Hey, Nika, what's up? First of all, congratulations. We helped secure some more funding for BCRI. That's dope. That's how the policy subcommittee rolls, everybody. So what subcommittee is next? This is my challenge to you all. But enough about that. Today, I'm really, really excited to welcome Nika. She's going to be doing a DEI presentation for us today. She's going to be talking about housing equity, Big Mama's House, and Anchor Institution. Nika really is an anchor institution when I think about housing in Baltimore. She's just so knowledgeable. And through Blight Baltimore, Nika's really helping make sure we take our vacants and abandons off the streets and help get more Baltimoreans housed. So I'm really, really excited to have her with us today.
Hey everybody, let's see if I can share my screen. All right, this is the one thing about Zoom that makes it difficult. Okay, it's going to give me, I want to be able to, I like to be able to see everybody's face. or as many people's faces as possible. I guess I'm not going to see everybody on here tonight. But in any case, thanks for Reha. Again, I'm Nika Namdi. I'm the creator of Fight Blight Be More and a co-creator of the Stop Oppressive Seizures Fund. And in that regard, in both lanes, the goal is really to make dope space and place for people to be. And so we've been doing a lot of work surrounding during the COVID times, surrounding tax sales specifically. And one of the things that we found is that more than 50% of the houses that are going to tax sale that are being exposed to this predatory practice in Baltimore belong to elderly Black women with incomes less than $30,000. And so been just doing a lot of thought about how folks are being exposed, how those particular folks and families and communities are being exposed to public policies like tax sale, condemnation, demolition, all of these different aspects of public vacancy, fire, hyper-policing, all of these things. And when you start looking at development in Baltimore, you start to hear a lot about, not just in Baltimore, but in many urban areas, you start to hear this term anchor institution. And thinking a lot about what an anchor institution is, I found this definition from the Anchor Institution Institute. I think it's the University of San Diego. And it basically, talks about a place-based, mission-driven entity that leverages their economic power and their human and intellectual resources to improve the long-term health and social welfare of communities. And that sounded a lot to me like what Big Mama's House is. Now, there are a lot of institutions that are given a lot of public resources and a lot of public support because they are thought to be or felt to be anchor institutions. Many of them are educational institutions or they're nonprofits, specifically hospitals, and they are given massive amounts of public support, government dollars, and private support through donations and other sorts of funds to do their mission, right? And they leverage those funds as well as the human capital inside of those organizations to supposedly promote or improve the long-term health and social welfare of communities. But oftentimes those institutions, those anchor institutions, do the exact opposite. While at least on a micro level, on a community-based level, Big Mama's House, the physical space, and those in leadership in these spaces often are meeting the long-term health and social welfare of communities. And so when we think about equity, we think about, really supporting or figuring out how we can, through policy, right, support healing, regeneration in community. And we want to, lift up this idea of actual anchor institutions, right? Because those are the institutions that are getting the public support in order to do the work. But Big Mama's House oftentimes is being left to decay under the weight of poor public policy, under the weight of speculators, under the weight of, all manners of, capitalism, you name it, right? But this is a physical space and place where people actually are developed into whole human beings, into functional human beings, into healthy human beings. And we a lot of times do not think about, and when I say Big Mama's House, I'm referring to those homes of elder Black women specifically, but it could apply almost universally, where, young people specifically, children and young adults are getting this extra resource. They're getting this extra care and feeding. Sometimes they are getting food, clothing, shelter, right? Sometimes that because people literally live in intergenerational homes, but sometimes that is a place outside of where you live that is owned by your family that you can go to and get your needs met. And so when we think about the economic piece of an anchor institution, it talks about leveraging your economic resources for the betterment of both the people who live in the house, your relatives, and the wider community. There are things in Big Mama's house, collectibles, of course. You know, Big Mama always got a little bit of something stashed in her breast to give the children, right? That real property, we talked about how it actually is a place where people can live, right? So it becomes a space that people can inhabit when they may fall on hard times elsewhere. And then the intellectual property, and that is this, you know, everybody, I talk about, you know, somebody's grandmother having, everybody's family has some intellectual property. It could be a pie recipe. It could be a particular way in which to knit. Like, these are all things that people, Big Mama uses that have economic value in order to support that house and the wider community. Ooh. Oh no. And when we go to what it also talked about their social power, right? And they're all into, again, this idea of intellectual power, you know, crossing the social economic boundary. Big Mama's house is a place where your personal bonds are formed. It's a stable location. You get a sense of stability. It's often the center of family life. It's where family and cultural norms are communicated, right? It's like in their family media. It's where those ideas are broadcast. And then on a community side of it, oftentimes this is the first place, Big Mama's house is the first place where people see organization and mobilization, whether that's neighborhood cleanups, whether that is people taking turns, taking plates to somebody who is sick and shut in, all of that, it also becomes a place where you may get daycare services. Almost everybody knows somebody's grandmother who will keep an eye on your children while you run to work or you run to the doctor's office. And it's also a place of service referral. That's the same place you go, like you're looking for a job, or you know what, you can go down here and talk to Mr. John, right? This is the type of social resource that Big Mama House leverages, that puts forward in community and creates. It helps to both develop the individual person, but also create a healthy ecosphere in the wider community for that person to navigate. But when we start to take a look at the neighborhoods that again have high populations of Black homeowners or Black residents, but also Black homeowners, and those same neighborhoods that have high populations of people over 65, we see it's the same, oftentimes it's the same neighborhood that are classified as within the Black butterfly. And if you remember back to previous presentations that I've done, these are the same neighborhoods with high levels of food insecurity, low levels of housing affordability, high levels of demolition, vacancy, all of the kind of negative things that we don't want neighborhoods to experience, or people in neighborhoods to experience, exist in these same neighborhoods. And that's because we do not invest public resources into Big Mama's house as an anchor institution. This map that you see in front of you is actually from the Baltimore Business Journal. It's called Crane Watch. So all of the projects, I think, that are over, I think $5 million are displayed on this map, interactive map that they call Crane Watch. And as you can see, the most of the heavy development, most of the public type of, many of these projects have elements of public investment, public funding, i.e. our tax dollars. They're centrally located downtown in the central business district and kind of sprinkled throughout the rest of the YL. The same thing, we think about TIF, when we look at the TIF net, you see a sprinkling of them in other neighborhoods. Most of the pilots and TIFs are, however, in the central business district and sprinkled elsewhere. So again, this is investment of public funds, often to anchor, in alignment with the needs or desires of anchor institutions as we understand them, the eds, the meds, the big nonprofits, but not public investment in terms of supporting the actual anchor institutions that are on a micro level, producing healthy, whole human beings, and also creating safe space in community, or creating safe community for those human beings to navigate. And so the central thing that I kind of wanted to throw around tonight or introduce is this idea of Big Mama's House as an anchor institution, but also suggest that we should be about the business of developing public policy that invest in Big Mama's House as an anchor institution, because when we lose Big Mama's House, it's a source of trauma, not only for the individual owner of the property, for the entire family, but for the community at large. And so I try to leave some time for some questions, dialogue, discussion, but that's where we at. And obviously, and all the time, if you know someone that's having some issue with tax sale, condemnation, demolition, the We Buy House folks calling them 50, 11, 100,000 times, please feel free to contact us, and we'll try to support them in addressing those particular issues.
First off, let me just say thank you so much, Nika. Love the idea of Big Mama's House as an anchor institution. I think that's really brilliant, and not something that I was thinking about. And so appreciate you for that, and also for your advocacy. I know, you've been in the trenches with our colleague, Councilmember Ramos, really fighting the fight on predatory tax sale. And that is very much appreciated, because it is nothing but a bad business for us to be in the tax sale business. It hurts the wrong people, and it frankly doesn't advance the interests of the city, in my opinion, either. So appreciate your work on that. And any questions from folks? I think I have one, but if anyone else wants to just jump in.
I will definitely share. I see something about sharing the PowerPoint. I'll make sure Fariha gets a copy of the PowerPoint to share.
So my question, Nika, is, in my job, we have not, our council, since we got in 2016, we have not been nearly as aggressive on TIFs. I think their time has kind of come and gone in some ways. I think the city has come to realize that the bond obligation is often not worth the squeeze. And I think what we're seeing, unfortunately, with Port Covington, which I will say was definitely pushed right before our council got in there, is that, the city puts itself on the hook for pretty significant liability. And if these projects don't work out, we get left holding the bag, which I think is kind of exactly where we're at right now. So all that said, we could talk about Mondawmin and Target. We could talk about Poppleton. It just seems like it has not been an effective instrument for advancing economic development. And I think a lot of cities have had this realization. I think California did away with them. I sort of feel like people have had a come to whoever you come to religiously moment as it relates to TIFs. And so I don't anticipate as much use of them, though, as we think about the Inner Harbor redevelopment, as we think about some of the other stuff that cities trying to do, could they come back? Absolutely. So I'm curious, like, if you could go a little more granular in terms of like what investment in Big Mama's House as an institution would look like what, you know, what it would mean for the city to invest back into that form of
Right.
capital versus like the traditional economic development model.
So I think one of the things is right now, because of COVID, there's the half money, which is state money via the Fed for, all manners of property tax, things to help people stabilize. I think that whenever any kind of federal money comes via the state to the city, or is available via the state to city homeowners and city residents, the city has to do a better job of making sure that residents are able to get access to that money. It's not exactly an investment, but it is public resources that are available that would definitely shore up many Big Mama's houses. So that's one piece. But in a wider sense, I think if we took a closer look at Dr. Lawrence Brown's social equity bond and how we could develop particular neighborhood-based councils or whatever that could take money from a social equity bond or from some other funding source, whether it is, people don't like additional taxes, but some other tax or fee, maybe on high level development, on projects over 5 million or projects that are going to generate, that are projected to generate, over a certain amount of money. And then each of the neighborhood councils would get that money and they could invest it in shoring up the neighborhoods, whether it was making sure houses have roofs, making sure people have homeowners insurance, making sure like meeting the individual needs of a particular community. So where Poppleton and Harlem Park are having issues with houses being in such bad condition that the only option is to demolish them, they may use their piece of the revenue generated from a social equity bond differently than it may be used in Park Heights or in Greater Mondawmin. So you get, developing these neighborhood councils gives more granularity to making sure that the particular neighborhoods get what they need, but that a general bond offering or some other vehicle for funding some very specific neighborhood-based interventions surrounding housing and other physical, because it's not just housing, it's recreation centers, it's parks, it's all of the amenities that kind of make up a community. So I think those are two things, like when the federal money is there, when the state money is there, the city has got to figure out a way to make sure that its citizens are getting what is due to them. And then secondly, taking a really close look at this idea of a social equity bond along with neighborhood councils to both define what is needed in those particular neighborhoods, but also to make sure it gets distributed appropriately.
Gotcha. No, I appreciate that. So making sure that money, when it comes in from outside the city, goes directly to folks on the ground, and also almost like almost participatory frame around how we distribute city revenue dollars and make sure that people in neighborhoods are not left behind.
Right. Because I think even with the TIFs, I'm sure we can go to the moon and all this other such stuff. We could create a TIF that was specifically for this kind of, a pilot specifically for this particular thing. And the likelihood that you're going to have better outcomes if it is centered around the people who already been living in community 30 and 40 years, those people not getting up and running when times get tight, like you see happening with some of these other projects. because these are people who have invested their lives in Harlem Park, in the 4x4, in, in Old Town. These are people who have invested their lives and everything in these particular neighborhoods. So developing some kind of vehicle specific, some kind of TIF or pilot specifically for these neighborhoods might be also ideal, but it really is about making sure that the people that are living in community are directing it and are the main beneficiaries of it.
Gotcha. All right. Anyone else have a last quick question? All right. Well,
I see Dr. Leaf had his hand up.
oh, sorry. Sorry, I can't even, all I got is your.
Not a question, but I think Nika raises a really important issue. The TIFs and all these things were focusing on large organization, multi-million-dollar organizations that were being encouraged to give community benefits. And as she pointed out, in many of our neighborhoods, it's the individuals, it's the coaches, it's the block moms who are using their own money to make benefits into the community. And is there some way, sort of in the same way that homeowners can get, that they've been tax deduction is something. Somebody's lived in a home for over certain years, or elders are getting money off their property taxes. Could there be a way of the community to really recognize that a lot of people in Baltimore City are using their own equity? It's a small amount at an individual, but if you aggregate it across a lot of people, it becomes a substantial amount of money versus at Johns Hopkins or University of Maryland or someplace else that, they're multi-billion-dollar organizations, and they're getting money in theory to be able to, to invest very large amounts of money in a positive way, where in many of our communities, it's the individuals who have the knowledge and are doing that. And might there be some way of, I'm not sure paying them, but giving them money off their taxes, some way that the city could create a benefit. So that they're getting, a tax advantage, because most of these people, again, don't, with the new federal tax law, all these they're donations, but they don't have an impact because they're not over the $20,000 or amount that the percentage that somebody would have to do to be able to have an individual not to use the group rates as opposed to the individual rates. But it strikes me there might be ways of doing it. Whether it's overall or in some of these high need neighborhoods where it's even more of these individuals and, the big mamas and the coach. I just use coaches as an example because most of the people I know are coaches in the neighborhood are putting a lot of their own money into not just their time, but their own money into buying the equipment for the young men or the young women and other kind of things. And they get the positive benefit of helping people. But, might there be some way that the council figuring out some way of getting this as a deduction or not having to pay something that otherwise they'd be paying, so it multiplies the funds that they actually have to spend?
Yeah, oh, sorry, go ahead, Nika.
No, I was just saying, I like it. I like it.
Yeah, I think it's a good point, Dr. Phil, and that you and Nika are making, that often the financial benefits don't accrue to the folks who are on the ground doing the most work, and just don't have the institutional credentials to get the grant or do the thing. I will say that I think this has been a challenge for the city. I think, part of what we were trying to do with the youth fund really was in some ways almost like a backdoor attempt at reparations with a participatory lens. I don't typically say this publicly because I know, folks will contort it in all different directions. But I think that what we were, what then City Council President Jack Young and folks were trying to do was to acknowledge that structurally, to your point, Phil, to your point, Nika, that there are institutions that have accrued a lot of capital and a lot of ability to get the grant and do the thing, and aren't necessarily reflective, A, of the communities that they serve, and B, aren't always like the most productive, good use of that money, because they're not the big mama's houses. And in some ways they may actually engender a lot of mistrust instead of the trust and the faith that I think people have. And I think that's really what we're trying to do, is like give to those groups, have a participatory lens on it. And I will say it was really hard, because like, I think people are just like not like, we don't have the kind of political imagination in a government framework for this kind of stuff. And I'm not saying we couldn't. And, look, I'll be the first to say, no one's perfect, but I think we have a mayor at the moment who is like willing to take chances on things. And I think we have a council that's overall pretty progressive, and certainly amazing advocacy within community, as we've just seen. But it is tough. Like it is like, government does not lend itself to outside the box. Like, how do we think differently about how we support institutions in a way to repair, what we systemically have done as government? Like it just like, because all of a sudden when we did that, it was like, oh, but like, where's the metrics? And y'all don't have enough data. And I don't like, a lot of institutions that have been benefited historically from the status quo were very unhappy, and we got beat up in the media. And like, there was just this whole narrative of like, oh, they're just like throwing money at, Black and brown led organizations. And
me, because I was a Baltimore Children and Youth Fund recipient. So yeah, they did. And guess what? It was effective, because we're still here and growing because of that money. I think the challenge is Baltimore's neighborhood problem is a $3 billion problem.
Yeah,
and
right.
The government, the council, everybody, DCHD, DPW, all has their role. But the biggest people who need to be called on the carpet to pay for it is the people who generated the most revenue off from it. So the banks, the real estate agent, like this is where it's, we gotta call people to the carpet. Like, it's time to, y'all been living good, but now it's time to pay. It's time to pay up.
Right.
So
yeah, especially when there's a history of, subprime lending and just the wreckage that in the, early 2000s and mid 2000s that banking institutions did in Baltimore and all over the country. But yeah, I mean, I think that's right. Anyway, great conversation. Love the work. Appreciate you for pushing it, Nika. Definitely let us know, let the task force know if there is a space to advocate and push in on what you're doing. And I want to do some thinking on my end and with Odette as well. With that, it's 6:12. I want to, before jumping to our subcommittees, I did want to share quickly the training. Folks will remember that Corey Witherspoon from the task force was able to hook us up with mental health first aid. So we are going to be doing a training on the 26th. So that's July 26th at 8:30 a.m. at City Hall. It is an all-day training. We will provide lunch. Maybe we could do breakfast too, Ann. That feels only just. Anyway, it's at City Hall. Ann put the registration in the chat. Would definitely encourage folks to check it out, to get signed up. I think mental health first aid is really important. And hope to see a lot of folks there. And then also Ann had something she wanted to share as well.
So there are just a lot of visitors here today, which is really exciting. And for the most part, I know where folks are going. I know which committee folks are here for. I just wanted to call out, I'm going to open rooms here when we move to committees. And the medical committee will stay in this main group. And so some of you are here for the medical committee, and that's great. there's a couple folks that I'm still not totally sure where you should go. So I'm going to tell you your options and I can put them in the chat. We have a decolonizing group that's working on decolonizing trauma-informed care structures. We have a youth-focused committee. We have a policy-focused committee. We have a training-focused committee that's working on developing training for community. Again, I know where most of you go, but as I open these up, if there's a couple stragglers, if you can put in the chat which group you want to move to, I can get you moved to the right place.
Awesome. And with that, we'll rock and roll. Dan, real quick, Desiree had a question. Will that be the only training?
So it's the only training that they're doing specifically for this training is geared specifically towards the task force and Healing City Baltimore Steering Committee. And they have been offering free mental health first aid trainings through the month of June. And I think there's still some in July. So I can get the link for what they are offering. But for the task force and Healing City specifically, that is the only date.
Awesome. All right. So with that, and we'll loop us into some groups. And I'll see y'all on the other side.
I think this group is fairly set. I'm not sure, Jasmine, I wasn't sure where to put you. So if you want to be, oh, Jasmine, you're with decolonizing. I know that. All right, I'm moving Jasmine to decolonizing. All right, I'll be with decolonizing, but I'll keep an eye because people sometimes get kicked out. So I may pop back in if people need to be reshuffled, but have a great meeting.
Thanks, Anne. Before we dive in, I want to take 2 quick seconds. I want to introduce someone who is new to Baltimore, but he's becoming family to all of us. So I want to give the floor 2 seconds to a new face, but I'm hoping one that comes and joins us frequently, he's bringing his talent from Ann Arbor over to Baltimore. Jack, do you want to take a few seconds to say hi? You're on mute still, just FYI, Jack. You're doing a rookie mistake one soon.
And that's just how it's going to keep going. Hi, guys. I'm Jack. So my last name is pronounced Iwashina, like I wash in a bathtub, for those of you who looked at that last name and said, what the heck is that? I moved to Baltimore a week ago. Don't have any of my stuff yet, but Panagis said, hey, you guys are doing good work, and I'm thrilled to be here to learn. During my day job, I practice as a medical intensive care doc over at Hopkins now, which means I'm a COVID doc, and I do some epidemiology research. Thanks for having me.
And I get to over in Jack's next, chapter of life. I'm taking him throughout Baltimore to kind of introduce him to the areas. Sunday, I'm walking him through Greektown and just giving him some insight. So more to come. So if anyone ever wants to do like these walk-in talks that I will be doing with Jack, you guys are welcome to come and join. That's it. And then I'm still hijacking. I want to, Tika, how are you doing? How's Planned Parenthood? Is there anything we can be doing for you, man?
To just tell you how I'm doing. I'm exhausted. Yeah, we're just trying to figure out and prioritize services right now. We're kind of short on staff, obviously. So please tell people to apply if they're looking for a DM, anybody, nurse practitioners, MDs. Yeah, we're just preparing for influx, and trying to move stuff towards like MABs, medical, pill abortion options and stuff like that that can be done on telehealth here in Maryland. So yeah. There's that. Please donate to your local abortion.
Got it. Tika, please, we're all here, so just keep us in mind what we can do more to help and so
No, it is what it is. Actually, you know what I was gonna ask you, Panageese? Do you know Jennifer Parks?
Jennifer Parks. Sounds familiar, but
I met her last week, I think on the 22nd. Was that last week or the week before? I lose track of time, but I'm hearing she's heading the transgender center.
Yes.
Can we send her a letter?
Yeah. Yeah, that's fine. Let's bring her in.
Okay. That is definitely a location that needs to be involved.
Sounds good.
That was like the only thing I wanted to make sure to come here and ask you guys.
Ask away, Tika. Don't pull back. Ask away.
No, yeah, that was it. That was the one thing I had written down. Was like, I gotta talk to the task force about this.
One to-do item, check.
Yeah, done. I succeeded. Anywho.
Well, glad to hear you're hanging in there, Tika. You're on the front lines of a really important battle right now, so appreciate you and everything.
It is what it is. Yeah, no, we're gonna fight for rights. It is your body.
Yeah.
Anyway, let's get to business.
Yeah, and welcome, Jack, and nice to have you join us. Would it be helpful if I kind of just, I guess, summarize where we're at with things, and then we can all just jump? I don't have any new ideas to lead anything. I can just summarize where we've been, and if folks want to jump in with where they think we should go next. Zeke did say he's going to jump in over here after he meets with the policy group because he wants to talk about the letters we were supposed to be sending to the hospitals. I asked him if he did it, and he said he was going to talk to us about it. So I will see what he has to say. It has something to do with the funds that we're going to get. I don't know. So we'll wait till he comes and he can tell us what the updates are.
Because on a side note, Lindsay, isn't that like kind of where we're in a pause at the moment?
Yeah. So yeah, where we are basically is that we're trying to set up parallel meetings with medical institutions in Baltimore, as well as community listening sessions with community-based organizations or groups in Baltimore. And the point of those parallel meetings is to gather information about people's beliefs and perspectives about how these institutions are operating from a trauma-informed perspective. From the community side, we have questions of wanting to understand, like, what are their experiences like in hospitals, medical clinics, mental health clinics? What would they like to see happen differently? Do they feel safe? Do they not? What kind of feedback would you give the institution, the providers, the nurses? And then hoping to use that to bring that to the medical institutions to guide the conversation there, which will be focused on, we have questions such as, what is your institution currently doing in terms of trauma-informed care? What do you need to accomplish, the goals of having a trauma-informed institution? What is your institution doing in terms of DEI initiatives? What is your approach look like? What is your system doing so that providers are operating from a trauma-informed perspective? How can you better coordinate with other institutions or between institutions? So those are sort of the hospital clinic focused questions. The end goal from there, after those meetings happen, is to somehow integrate what we learn together between what is happening, what institutions are doing, how the community is feeling things are going, and to have some kind of dialogue about where the gaps are, what needs to happen for these institutions to be either trauma-informed period, because they're not at all, or better functioning as a trauma-informed system, and to really have that guided by the community, not asking, just for the hospitals to tell us that we want it driven by what the community says they need. So that's sort of where we're at with the long and short of what one of the goals is. And Jack, we'd be happy to share with you we have a Google running doc of all the conversations from our meetings. Michael sends out great notes afterwards about what we talk about. Thank you, Michael, always for reminding us of what we discussed is really helpful. And so, yeah, that's where we're at. We do have other goals of wanting to implement trainings in in these institutions that are trauma focused, partnering with, what was the word we used? It wasn't non-traditional, trusted spaces, more trusted community spaces where medical care sometimes happens. So churches and other neighborhood-based groups. So there's several different goals, but the one we're sort of working on now is just gathering information, conducting these meetings, trying to initiate the dialogue between communities and institutions. In order to make it a little bit more manageable, we narrowed it down into 3 main institutions that we want to try to have conversations with, and those are Hopkins, University of Maryland, and where I work, which is Mount Washington Pediatric Hospital, which is the stepchild of Hopkins and University of Maryland. So it just felt natural to bring those 3 together. And Zeke, we said, I know you said you're going to pop over. Folks are wondering, where we're at with setting up meetings with the medical groups and the letter, and if there was anything we need to do more there before we talk about the community meetings.
Yeah, no, thanks, Dr. Gavin. Good to see you all, and hello, Jack. So yeah, I wanted to, before sending the letters, I wanted to just circle back, simply because, and I mentioned this in our last task force meeting, but we were able to get this grant from AmeriCorps in partnership with Baltimore Corps to be able to place 20 what we're calling Healing City Recovery Corps folks at either medical institutions or organizations like Fight Like Baltimore, potentially our libraries. But the idea is for them to be navigators and to support the health and particularly mental health of people in community, and to sort of be a bridge. This all kind of came out of conversations that we were having, Lindsay and other folks, pretty early on with Sacred Heart Church, where they were able to embed a clinic for COVID shots for the vaccine within the church. And as a result, the demographic that they serve, which is our Latino community, went from being just profoundly harmed by the pandemic to the most vaccinated community in all of Baltimore. And so to Lindsay's point, the idea of embedding care within safe, sacred spaces, I think is really important, and I think really works. And so the only reason I want to just quickly pause on sending the letters is that I do think as we engage this conversation with the medical systems, I think one of the things that we should potentially build into the conversation are these navigators. And again, these are folks who we can hire from within community. There's no degree or educational attainment background that they're required to have. They would get paid, I think, $36,000 over a 10-month period. So it's not like, it's not amazing pay, but it's definitely, above living wage. And, and again, it could be folks from the church, which I know is one of the things that Bishop Bruce had really wanted. We could have some folks from West Baltimore, some of the churches over there directly working with University of Maryland. We can have some folks in our libraries doing the peer recovery work around substance abuse. But that was all before sending the letter, which I intend to do, I think, tomorrow. I just wanted to take a quick pause and just put that out there, is like, I think that somewhat changes the conversation for us, in that it's not just like us asking them to do stuff, though we still should. But I think what we also now are able to bring to the table is folks who can help navigate medical systems and bring in a preventive approach to medicine for people that are distrustful of medical systems. And, what we heard loud and clear, Lindsay and Panagise and others who were there from the church, from Sacred Heart, was folks just don't trust Hopkins. They don't trust Maryland. They don't trust Mount Washington. Like people just, they hear stories of like someone came in and they got a huge bill and they couldn't pay it. And I think what happens is that as a result, people don't do as much, like don't do preventive healthcare and only come in when something catastrophic has happened. And as a result, they then do get hit with a huge bill and they come into the ER and it's inefficient and it's not good for anyone. And it's not good care. And there's no real follow through or follow up. And so I think the opportunity that we have, that this subcommittee in particular has, is to really try to change that paradigm within Baltimore and really try to build a workforce of folks from community that can be a better bridge to medical institutions and destigmatize and depathologize some of what happens in the hospital, and also, expand care into, like Lindsay said, churches, mosques, barbershops, and other places. So wanted to just drop that, and yeah.
So the community health workers,
yep.
I think their funding has sunset, and I know of several hospitals, like I know Hopkins didn't pick them back up. And we're trying to repurpose as much as we can. Could that be a bit, like, meaning what I'm trying to allude to from here is we could help retrain those individuals if there's funding for them to do more of the, like, this is what I was hoping CHWs would be doing, but they didn't. And they were to some extent set up to fail with what the system wanted them to do. But this is better from a cultural approach, a community approach. So what I'm alluding to is, is there a consideration to rehire some of the CHWs that are being let go by some of the entities and institutions, or is it kind of open it up and hire whoever applies?
Could you say a little bit more about, I don't know about the CHSW's letters?
Yeah, so community health workers, and I'm tiptoeing here as much as I know. Stephen may know more, being higher leadership at Maryland, but like when the Freddie Gray uprisings happened, there was a variety of commitment towards hiring certain personnel, and CHWs kind of came out of that, community health workers. But the funds were for a very specific amount of time. And I think like Hopkins, I'll speak about this. And you know what, it was hired in a sense of like trying to help out with pop health strategies, like lower readmissions and so forth. They're not being picked up again at the moment. And so many of us are trying to see if we can repurpose them in some capacity and variety. That's it. It's just, and it wasn't Hopkins money per se. I think it was state funded to some extent. So that's it. So there will be a variety of community health workers who just need to be.
Yeah, got it. So I think, I think the short answer is possibly, which is not a satisfying answer at all.
Understood. No.
I don't want to get ahead of my skis. I want to make sure whatever process we come up with, that it's equitable, that it's thoughtful, that we sort of consider all factors. But, potentially, yes. I mean, that is those are the kind of folks we want to hire. I think that there's two opportunities here. One is for us to really do some design thinking around what this could and should look like, given, what you just said, Panagise, and really what I've heard from Tika as well, which is that just having folks go navigate some stuff isn't going to do it. You're going to set people up to fail. So I think there's an opportunity for us to both do some real design thinking around what that should look like, and to partner with the medical institutions, but also groups like Sacred Heart, groups like Build. Marvin McKinstry is a pastor in West Baltimore who is just deep in the community. Groups like Central Soul, I see this as an organizing opportunity and an opportunity both to employ folks, but more importantly, to build out a more connected system. I would love to learn a little bit more about the community health workers and like what happened and why it didn't,
right. And I'm not trying to put anyone under a bad light. It could have just been politics. But one thing that I've been liking about this is CHWs were hired to work for the health system. This angle would be CHWs are hired to work for the community navigating the health system. That in and of itself could be more of a revolution and actually a more appropriate fit than having them work for the health system. So just an FYI.
No, I think that's right. I think that's an important piece that, the hiring here, the value is really should be more so on the community side. Not to say that the medical institutions won't benefit, because let's be real, like, this is potentially good for them as well. But I think that the frame should really be, how does this benefit community first and foremost?
Agreed.
I have a couple questions too. So would the healthcare navigators be like, are they assigned to certain institutions, or this is just like they would be trained to work with any institution?
So I think the thing we would do, this is how I understand it, is we've got a little bit over $1 million to hire 20 plus people. We've got some money to staff it, right? To like supervise and manage. And I think the thing that we would do is build a cohort, thinking strategically about who the partner organizations would be, i.e., a couple of folks from Bishop Bruce's church, the leadership team that he had mentioned he really wanted, that could really support that community. And I think work out of the church in partnership with Central Soul, Esperanza Center, Hopkins, and the various institutions that encompass that part of East Baltimore. And I think you could see a comparable thing in West Baltimore with Maryland, and potentially, Lindsay, with you all at Mount Washington. But I think that like they would work for they work with the partner organizations. They'd be supervised by us and Baltimore Core. So like they would be the Healing City Recovery Core. And so, the direct supervision would come through staff that we get to assign. And then they would work in community and in Hopkins or Washington or Maryland. Or even potentially, again, we could put some folks in the library. Like right now, I think I've mentioned this to you all, but we've been doing this peer navigator, peer recovery coach in the library thing. We started in Penn North. We're now in Penn North and Brooklyn, where instead of zero tolerance and criminalizing people struggling with substance use, we have instead brought these folks in who have been through active addiction, who are very, very well trained. They get like huge amount of hours and certification to be able to support people to get, whether it's treatment, if they want it, Narcan, housing, healthcare, whatever the need is, as people identify it, that's what we support with. And, a couple of these folks could go and do that work. So the nice thing about this grant is it's not, I just reread it today, it's not terribly prescriptive. We can kind of like build some of it as we go. There's definitely got to be a trauma-informed care component to it. So like at minimum, at baseline, folks are learning mental health first aid. We're putting them through some kind of training around trauma-informed care. We want this to be a culturally competent, trauma responsive cohort of individuals that, comes from the same places that they're going to serve. So sorry, that was a longer answer than your question.
No, it was very helpful. And I just had just one final question. If anyone else has questions, definitely jump in. But my other question was just about, so the 10-month position is funded through these grants. Is our idea then we would apply for additional grant funding to keep the positions going, or eventually somebody else kind of picks it up to kind of maintain the position? Because the only thing I'd be worried about is those, I think it's traditional, the programs that kind of come in and pop out and then they're done, just like
this is a great opportunity to let those be models for these institutions as to what if you want to navigate or what it should look like. Right? That's a great opportunity to let that be that.
I agree, Tika. Lindsay, to directly answer your question. So what's nice about this, from my understanding, and I want to bring Sarah Fleming, who's the vice president of Baltimore Core, and have her sit with us and explain a little bit more of the opportunity. She wrote the grant and I think can articulate it better than I can. But the short answer, Lindsay, is there is the opportunity for as many re-ups as we want, as long as we're producing data and showing that we are in some way getting people into the workforce and reducing some healthcare disparity, whether that means more people are getting mental health care access, whether that means more people are, diabetes, blood pressure, pick your thing. But the short answer is, yeah, we can, as long as it's going well, we can re-up the grant indefinitely. And it's a federal grant, it's through AmeriCorps, and it's good. It's value add. It's not like it's coming out of the city's pockets or anything like that.
Right.
I think this is a great opportunity. Zeke, I think it'd be great if we could spend some time with some healthcare navigators now and understand what the end game is, so that we don't develop a program that is destined to fail. So I think we should be. It would be very helpful to get very concrete understanding of what we can expect from a healthcare navigator and how they can actually make a difference. Because my internist just retired. It's been 3 months. I can't find another internist in the city. Go down to our emergency room, adult, not pediatric. Pediatric, we do a much better job. Go down to our adult emergency room. It's wall-to-wall people. So
yeah,
I don't know if the capacity is there. I know there's capacity for certain things, and maybe we should figure that out. And I know that there are other resources besides the big 3 or 4 institutions, FQHCs, Chase Brexton. So there are FQHCs throughout the city that could help. And I'd be curious to find out if some of these navigators can be somewhat specialized, like for prenatal care, mental health, diabetes, hypertension, pediatrics, because it's asking a lot of a navigator, in my opinion, to be able to direct dozens and dozens of potential medical issues. But I think this is a great opportunity. I think even small victories would be really important here. But I think it would really help me if we had some of these navigators, the ones that are successful, help explain to us how they're doing it. Because if Zeke, if you called because you want to get one of your kids in to see a pediatric specialist, regardless of everything I've done, you're going to get told 2 months wait. If you call me, you'll get in the next day, because people appreciate who pays their check. But and Lindsay, I don't know if you feel the same way. Like Mount Washington, it's that we're overwhelmed, but that doesn't mean we can't do this. So I think we should just try to get as much information up front about what the opportunities are, and maybe target 1 or 2 things to begin with. and then have the program grow. But I'm all in, and I think we need to take advantage of every, medical mental health resource in the community, and many of those are not affiliated with the big 3 or 4 medical centers.
Yeah, Steve, it's funny you took like words out of my mouth, because I was just gonna say, like, when I think about making it more accessible, like that's absolutely what we need to do, especially for marginalized groups. And then I think about how we can't even handle how many patients are coming to us currently, because we could stuff the whole hospital with psychologists, and there's still not enough psychologists, and there's still not enough mental health clinicians to see the kids that are just flowing through every day. Our wait lists are months and months long. Parents call us in a panic because they've gone to 5 other places where the wait list was always also months and months long. So they're going to all these places where there should be, the access is there. It's just that there's not nearly enough of us to help serve, and everybody's very overwhelmed. And we have one child psychiatrist in the entire department that serves hundreds of children at Mount Washington, and haven't been able to hire a child psychiatrist for many, many years. It's been really difficult. So,
and we're saying this out loud, but again, to a community who, especially if they don't have any insight into medicine or have never gone, this could be something that fuels them and creates more of the distrust. Meaning, like, hey, am I not getting seen because I'm of this denomination, or if I'm because of where I live and so forth? We, like, these health workers, Zeke, could help us with this kind of medical translation of like a lot of frustrating aspects of it. But that's where I'm hoping they can help mitigate until we figure out on our own end how to solve a lot of these issues.
The other thing, I just want to add one thing real quick, and then I won't say another word. Zeke, I think that we should also try to be very creative. And we've learned how to use telemedicine, telehealth, because of the COVID pandemic. I think we can extend or expand our capabilities. Not all the time, but I think some mental health counseling or interventions can be done with tele. Maybe not the first one, but some. I think some initial visits can be done with telehealth, and maybe we need to just make this a paradigm shifting approach. The navigators are in touch with a group of resources that can interact, if necessary, telehealth to get some immediate input to the issues while we wait for an appointment. But we're gonna, there are ways, I think, creatively we could extend or expand our capabilities. This would be a great pilot to look at that. And it may not work, but I think this would be a great pilot to consider, seeing if we can take advantage of technology to the extent we can to expand our capabilities.
Yeah, no, listen, like, first off, I hear you on just the basic capacity challenge. I mean, I probably mentioned this to most of you, but my wife is a physician in Cherry Hill, and she's a psychiatrist, and she got more patients than she knows what to do with. I think that is reality in every medical system and every, mental health system in the country right now, is like everybody is over capacity. I think, Steve, your point is well taken. I would also say on the tech piece, I mean, I know, again, my wife does a lot of telepsychiatry at this point. Everybody started doing it in the pandemic, and she's still doing a fair amount of that. For some patients, it really works. For others, who may not have technology, it's a challenge, but it's been really interesting because I think it's eliminated a transportation barrier for a lot of people. But all that said, I think additionally, there's also an opportunity with these folks that while they may not, in 10 months, they're not going to become a full clinician. I think that learning mental health first aid, being able to support people at a kind of basic level, some of the work that Monica's been doing with Central Soul, where she's got, it sounds like community health workers doing some group-based clinical work. Like, I think there are some creative ways that folks could both help people navigate the formal medical systems, but also just support on the ground and validate, people's real struggles. Because I think everybody's struggling right now. Like, I am hard pressed, real talk, to find many of my friends or family or constituents who are not going through it in one way or another. And I think that's just reality for most people. In this time. I think it's the pandemic. I think it's all the toxic stress, but it just seems like we're out of kilter. And I think there could be an opportunity for these folks to help to support on the ground as well. One thing I did want to ask, Tika, I don't want to put you on the spot, but I know this is a world that you are very adept in. And so I did wonder, to Steve's query, would you feel comfortable, or do you think like we could put together maybe like a little presentation on what successful navigation looks like? I know the work that you've been doing at Planned Parenthood. I would also be very curious. This is a world that I'm learning about as I go, but you've been doing it for a while, and I think doing it really well. So be curious, one, your thoughts, and two, whether you'd be willing to put something together for us and maybe bring either just you or bring some folks.
I was actually marinating on that, actually, as Stephen asked. How soon would you need it ready? Would be the question, because I think I could probably put something together, but like not tomorrow.
Maybe next task force meeting.
I think I could do that. Yeah, I'll put that on my schedule to do on there. But second thing I was gonna say, do you have like maybe specific like concerns or questions that maybe I have two different navigator groups, a national one for the Planned Parenthood Federation, and I have a local one for the DC, Maryland, Virginia region. So I was hoping like I could reach out to them. Obviously our meetings are monthly and probably not going to work out, but I can definitely send them like a survey or, a questionnaire, and then I come back with that info too. That way it's not just my one-sided view of care navigation.
What would help me personally is to just understand how they spend their day, like run through meeting with a few clients, how long initial interaction, and what's the disposition. So meet somebody with a mental health issue, or meet somebody who's not feeling well. What are the steps in trying to help that individual, and maybe a sense of what resources are currently available, because out in the community, I think that would help me crystallize how we might move this forward. But that's just me. Okay, but that would be good for understand.
That makes sense. And what you were saying is also true. It really is mostly like almost like a service line, depending on what the patient is needing or where you meet them at. Like for me, a lot of the needs I'm looking for are like family planning needs and like trans care needs, some undocumented folks, but like, again, it trickles down and really depends on the demographic of people walking in our clinic versus who's going to be walking into like Hopkins or even like the church setting or whatever. That's going to really depend and guide a navigator in their work. But yeah, definitely I can come up with a couple stuff and ask some of my friends for a couple of insight and have something for you guys next task force.
And I guess the only other question is, if I understood that, I may be slightly overqualified, but what's the opportunity to volunteer as a navigator? So it's great that the program's going to fund navigators, but I don't think that's going to be nearly enough for the city. So could we use some of this funding or visibility to try and encourage volunteers. Obviously, there are ground rules, and they have to be vetted in the whole 9 yards. I get that, but could we use the grant to hire navigators, and could we maybe encourage others who have some skills to volunteer periodically as navigators?
Yeah, I mean, I think possibly. I think, my sort of off the top response is that, my sense, and again, I don't know this world well enough to really, I'm pontificating a little bit here, but is that like it is real labor and it is real work, and to do it well, folks generally should be compensated for it. That said, are there opportunities to plug in? Are there opportunities to support and build a pipeline? I think so. I think there's always, we can always get creative with it. There's some very creative folks on this subcommittee, and I think we could probably figure that out. But, I do think that, paying people for their labor, compensating folks for their labor is important, especially when, with, populations that have experienced marginalization and that often get asked to do some stuff for free. And I know, Steve, that's not what you're suggesting at all. But I think it's important to lead with this is a paid position, and then figure out where's the opportunity for, I don't know, retirees or people that want to plug in. Does that sound right?
I think, Steve, it's hard because it's not like a call center or something where you're just kind of taking a note. This person might need a navigation that takes 3 days. I call you back tomorrow to finish this because we got to wait on the phone for 2 hours again. And that might, take a long time, and a volunteer could possibly do that. So.
The other thing I actually, and this got me thinking, Steve, that I want to volunteer or throw out there is, I actually think it would be useful for us to do a field trip to Penn North, where we've been doing this peer navigator around substance use thing. Donna Bruce, who's also a member of the task force, is in charge of that program. She's the supervisor for it. And I will just say, I was down there in Brooklyn today and watched her engage with this person who was experiencing homelessness, and she was living in an abandoned building with her daughter and her granddaughter. And the way Donna was able to get her to open up and be vulnerable and accept support, it was amazing to watch. I was just blown away by just the skill and compassion and ability that that takes. It's stuff that I couldn't pull off if I went up to someone who was walking around a library and was kind of eyeing me. She just had an ability to do it that I was that's incredible. And so I think it would be instructive both to have Tika, you come with some kind of presentation, and also if folks are amenable, for us to just go out to Penn North, pick a Tuesday or something, if folks have an hour, and go meet with Donna, go watch what she does. Because again, today it was, we were giving out Narcan. There was the no hunger zone van that was given food. And then there was also, again, this woman, and the problem was she was homeless. And so it was a call to the mayor's office of homeless services. And then they connected us to healthcare for the homeless. It's just this whole thing. And then, we went down this rabbit hole. But ultimately, she got the woman into housing. And it was cool to see. So I would throw that out there too, is that I think one way of being able to visualize what this looks like from someone who's really good at it would be to go over to Penn North and watch Donna do what she does.
I agree. I think what Tika could put together for us, and then also what you're talking about, Zeke, would be really helpful. I know I'm new to the idea of healthcare navigators and how that works and what I understand the idea, but what that actually looks like would be really helpful to see in demonstrations. That'd be great. So I know we're ending in 2 minutes, but it sounds like we're going to try these things concurrently then, Zeke, like, the healthcare navigators piece, getting that set up, and then also continuing with trying to do these meetings, sending out letters, setting up, that stuff to get that process started too.
Yeah, here's what I think in terms of next steps. And Michael, please take a note and then remind me I said this so that I don't forget. Is I think tomorrow, send the letter to the medical institutions. In all likelihood, I don't know, 4 weeks, 6 weeks, whatever it takes to set up a conversation with them. So we do that tomorrow. We schedule a trip to Penn North, and Anne can help us coordinate around that. And simultaneously, we start to build a core team around this navigator piece with the folks from Baltimore Core and some others, and just think about like what it could and should look like. So I think it's 3 action items. 1 is the conversation with the medical institutions. 2 is the building the core team around navigators piece. And then 3 is what was 3? 3 is what's that?
Okay.
Sending letters.
With your trip to Penn North.
Penn North. Yeah. No, 1 is the letter. So
Okay.
yeah, the letters, Penn North, and core team around the navigators. Michael, you got all that?
So may I ask, if you're going to send out the letters,
Yep.
can you CC the individual members of the task force that are at those organizations, or can you email them? Because you send the letter to the University of Maryland. If I know you sent the letter, then I can go and start to make phone calls and get people's attention. So it would really help me if I were CC'd on the letter, or if it was just emailed to me with a short note saying, hey, we sent this out this week. So I can start working on my team. Otherwise, it'll go into some folder and
and whoever the legislative person who's supposed to deal with me will.
Right.
Yeah.
So if I know if I have a copy of it, then I can go and push. In a nice way, but
Totally.
Otherwise nothing's going to happen.
Yeah, no, I get it. And my intent is to include all of your names on the letters.
Are we still, is everyone signing it, or are we just going to have everyone's name?
Yeah, just get everyone's name. I mean, it's going to.
Yeah, that's fine. But email or CC it so I have a copy of the letter, so I can walk to Dr. Sant and say, hey, did you get this? And when he says no, I can say, well, here's a copy of it.
Timestamp 11:30.
Right.
On it.
Yep. Right, sounds good. Thanks, everybody. Thank you, Zeke.
Michael, yep, you got that. Perfect. All right. Appreciate y'all.
All right. Have a good night, everyone.
All right. Bye.